Should we make a start? We've kind of been chatting casually. It's lovely to see everyone. Thank you very much for joining. Some other people may join. Our last one, which was about a month ago, was mainly about the radiation safety simulation, and we got a lot of great feedback from that. There's a lot of interest in that now as a continuing professional development tool. And I know there are some trials going on in Japan where they are using it in 31 hospitals to see if virtual reality radiation training is as effective as didactic sort of training. And I think that's what has been sort of the moot of virtual reality for the last decade. There's been people trying to see, both in surgery, in radiography, in nursing, and midwifery, you know, we've got this new technology. Is it a fad, or is it a really good learning environment? And from the results, which, I mean, as you all know, takes years to publish. In fact, while we say the P word, I should just direct you to Ellie, who published an article, I would say 2 months ago, in Radiography, which is a UK journal, and that is on our website with permission. So if you go to the publications tab, the first one on the right-hand side is Ellie's publication, so you can read that in full, which is great. But yeah, the results of virtual reality have been very good. There's obviously different sorts of virtual reality, and I think you have to be quite careful who you choose. We do get good feedback, which is really nice. We've always sort of said we're an educational company rather than, we're certainly not a gaming company, and we're not a big company who are absolute mercenaries just trying to make a buck. So I want to present, you've heard me talk to Ellie. Ellie and I have known each other for years. I think 4 years now that you've been using our software, which has been great. She went off on maternity leave at one point, but luckily came back, and I'm sure the University of Nebraska were very happy about that. And she's, as I mentioned, doing her PhD, so I'll let her tell you a little bit about that and what it involves. But I know she wants to talk about the Kolb's experiential learning theory and how they use simulation in their environment. They have a sort of a unique setup in the University of Nebraska. And correct me if I'm wrong here, Ellie, but you have two campuses, Kearney and somewhere else. And you have students in both, and you do teaching in both, but some of it is videoed, is that right, and sent to the other location?
We have 5 program locations. So at the time of this study, it was 4.
Right.
But since this study, we've added another. So we do our instruction seamlessly across campuses. So our students are connected on their campus through Zoom, and the instruction's either coming out of Kearney or Omaha, which are what we call our 2 campus locations. And then we have 3 program locations.
Okay, brilliant. And I think, correct me if I'm wrong, but I think you were a lecturer I was talking to during the peak of the pandemic, and I said to you, where are you doing this Zoom call from? And you said, in my car, because it's the only place you could get peace from your children, so you had to pretend to go shopping. And I was just like, what a brilliant idea. And I've definitely taken that out. You know, you raise the garage door, you get in your car, you slam the door, you close the garage door, and then you can have like 40 minutes of peace or something. Anyway, I'm going to hand you over to Ellie, who's going to talk about Kolb's experiential learning theory and how she uses our simulation in her classroom. And I know she's very keen on having some questions. If you can put them in the chat, we can, well, I've opened that up to everybody so we can come to them later on. So I'll hand over to you now, Ellie. Thank you very much.
Thank you, James. And thank you all for joining us too. Like James said, we're going to talk about Kolb's experiential learning theory and then how we've used virtual medical coaching in combination with Kolb's to teach image evaluation. First, I have no conflict of interest to disclose, and I would also be remiss if I didn't have an acknowledgements page. This work tonight is based off of my dissertation work. I graduated in December of 23, so James, I have wrapped up. I am finally on the other side. Faith, you two will get there. It's a wonderful place to be on the other side, but I'm graduated. This was culmination of my work. Hopefully some future studies coming. We ran lots of different statistics. We looked at a lot of different things. And so the publication that we're really proud to have put out in June covers the main findings, but we have some perception findings, incidental finding with the distance ed piece that we're going to talk a little bit about tonight. And then also some other studies planned coming out of that work, hopefully. So a huge heartfelt thank you to the people listed on the slide. Ashley's connected. Ashley Ballier is my program director, and she and our other radiography faculty were great, immense support in not only just aiding in validating findings and also helping me grade essays, but also just in support in getting this work done and completed so I could graduate. Would also be remiss if I didn't thank my supervisory committee. I'm convinced, the best doctoral committee there ever was, and it made a huge difference. I'd almost do another one just to have the chance to work with them all again. Objectives tonight. After this presentation, you'll be able to explain Kolb's experiential learning theory, use Kolb's experiential learning theory as an instructional framework, differentiate between immersive and non-immersive VR, which if you're already using, likely you already are aware, but just to make sure that we're all on the same page, we're going to talk a little bit about both and strengths and limitations of both. And then also we're going to talk and summarize the results of the publication that we had in June. That's going to be a very brief description. I'm hoping I can fit everything in. So we may, by the time we get to the results, skim over some things. Again, like James said, my name's Allie Miller. I work in radiography education at the University of Nebraska Medical Center. We're in the College of Allied Health Professions, where I'm an instructor and didactic education coordinator. James had introduced this or alluded to this at the beginning, but something just to keep in mind as we talk about this study is our program is kind of unique, and this is the only place I've ever taught. It's my everyday, it's my normal, and I think sometimes when you're in your normal, you sometimes forget it's innovative or it's unique. And so I just wanted to make sure at the beginning to talk about our program. It's 21 months. We are a bachelor's degree program, so our students come to us with some prereqs. We have 5 program locations, and I really should add the state of Nebraska because I understand a lot of people, you probably aren't very familiar with Nebraska from where you're all at. Nebraska's a little tiny state in the middle of the US. We have 5 program locations. So Omaha is on the east end of the state. It's very metropolitan. It's our largest city in our state. We have up to 17 students in that program location. And then we have Kearney, which is where I am located at. And we have up to 12 students per cohort in that location. And then we also had, at the time of the study, 2 more rural hospital sites with fewer students. But now our program's grown since then, and we have 3. So we have 5 total program locations. When we teach synchronously, our instruction's either coming from Omaha or Kearney. Those are our main locations because they're on a college campus. We're all within the NU system, the University of Nebraska system. So Kearney's location is actually on the University of Nebraska Kearney's campus, but we have a partnership. So UNMC is on UNK's campus. So kind of unique in that regard. We have anywhere from 34 to 37 students per cohort. And then we have our first year and second year students who we often call our first year students juniors and our second year students seniors because of that bachelor level. We're an integrated curriculum. So that means by week 5, our students are both in the classroom and clinic at the same time. I know programs can be different in that some do a year of didactic, then a year of clinic, but our students have everything integrated right away. So they're seeing it in the classroom. We're learning about it in the classroom. They're seeing it demonstrated in lab. They're practicing in lab. And then they're also out with a registered technologist, seeing actual exams performed on real patients and working with those registered technologists to get their hands-on and get hands-on practice all at the same time. So, there's strengths and limits to either way you look at it. We think our students have a lot of opportunities to connect dots and see it from a lot of different ways, and they're integrating those concepts all at once. A little bit of background. I'm going to be telling you things you already know, you're very intimately familiar with as a radiographer, or especially if you're in radiography education, which I think we all are, but just to articulate them to set kind of the stage of what we're going to talk about and why it's so important. So we know the role of a radiographer, but we going to perform images, We're positioning patients, we're using ionizing radiation, we're performing or producing diagnostic images of internal anatomic structures, and then we need to evaluate those images for diagnostic acceptability to send those images on to the radiologist for interpretation. I know in the United States that's maybe a little different than where some of you practice. I know globally it may be more of a provider or an advanced radiographer interpreting some of those images. Here in the US, we have no interpretation. That is always sent on to usually a radiologist, but someone higher than where our profession's at. So we're not doing any interpretation. So when I say radiologist, you can replace that with interpreter if that's more what you see in your practice where you're at. Bontrager, we know the goal of every radiologic technologist should be not to just take a passable radiograph, but an optimal one that can be evaluated by a definable standard. So in our program, we use the definable standard is a 3-piece standard that comes from our textbook, Bontrager's textbook, or of radiographic positioning and anatomy. So there is anatomy, positioning, and exposure. And so we really focused on this study of the anatomy and the positioning. So what anatomy do we need to see on the image, and what relationships can we see on that image to tell us that that patient was positioned adequately to give us a diagnostic image. And this is a radiologist, Dr. Berlin, in 1996, was quoted to say, radiologist accuracy can be no greater than the quality of the radiographs presented for interpretation. And again, we all know that to be very, very true. And the implications of when we're passing less than high quality images. We also know ionizing radiation carries inherent risks, and we know that we have an ethical obligation and moral responsibility to protect patients from unnecessary radiation exposure. And important to note that that includes minimizing rejected and repeated imaging due to technologist error. So when we look at repeated and rejected images, we know that rejected images are those that don't meet the definable standards for diagnostic interpretation, and then the technologist must correct the error and repeat the exposure, creating a new diagnostic image that's now acceptable. We know that we accept that the risk from misdiagnosis from inadequate information outweighs the risk from additional radiation exposure from that repeated image. And we also anticipate that there will be some repeated images due to the precise patient positioning and alignment required to obtain a diagnostic image. However, the transition from film screen to digital imaging decreased the amount of repeated images due to technical errors, but it led to an increase in non-technical errors due to the skills of the radiographer, mainly patient positioning. So today, roughly 8 to 14% of patient exposure is due to those rejected and repeated images. And patient positioning errors are the #1 cause of rejected images and repeated patient exposure. And I think my own personal interpretation, I think part of it is they became #1 because we dropped some of those technical errors, the ones that, our technique now, we can be a little looser and the computer can fix that. And so we're not repeating like we were on film. I also think we've gotten lax as a profession, and some of our patient positioning skills aren't as strong as they were when we were using film either. And so I think we're kind of meeting in the middle where that patient positioning error is becoming the #1 cause. Sure, some of it is because the #1 cause fell off. And then the other part is I do think we aren't as strong in positioning as what we used to be as a profession. So then looking at the structure of radiography education, we're not unique. This is many, if not all healthcare profession education programs run into this, but we have 2 components. We have didactic and clinical education. Within didactic, we have classroom and skills lab. Not going to talk a whole lot because you all are very intimately aware of what that means. Then we have in the United States, our credentialing bodies, the American Registry of Radiologic Technologists, and our registry board exam is written over 36 mandatory and 34 elective procedures. So this is covered under the written exam. And then students show their competency during the program through their clinical comps for those 36 mandatory exams and 15 of the 34 elective procedures. But what we have is we have this inherent separation of didactic from clinical skills. And so we have this theory practice gap. And so certification alone can't ensure safe and competent patient care. We have to be able to connect theory and practice to work safely and effectively. And we have these theory practice gaps. And whenever we have these theory practice gaps, it sometimes leaves it on the student to make sure that they're bridging that. So what can we do in radiography education to help them bridge that and intentionally bridge that gap for them? And so when we're able to close that gap, we can teach more effectively, and our students are learning at a higher level and able to then perform at a higher level. So moving into Kolb's experiential theory, this theory theorizes that learners create knowledge through the transformation of experience, and there's two dimensions. So we have grasping experience on the top and bottom, and then we have transforming experience right to left. So what grasping experience means is that the learner's taking information in. Transforming experience then means that they're interpreting and acting on that information. From these two experiences, then there's these 4 steps that are created, and these are these 4 stages. And the stages are concrete experience, where they're encountering a new experience. And then they move into reflective observation, where they reflect on experiences from multiple perspectives. And then from there, they move into abstract conceptualization, and they're creating concepts that integrate observations into logical theories. And then they're actively experimenting, where they're applying those newly formed theories to solve problems. This is a cycle, and you can think of it less like a cycle and more kind of like a tornado or a spiral going down. They're going to continually go around. They can start at any stage, and they just keep working around that cycle and drilling down their knowledge. And so within these 4 stages, there's also, if you notice, there's, let me think here. There's do, think, do. And so we have these different modes. We have grasping experience, transforming experience. We have this acting or this doing, and then we have this thinking or this reflection. And so the learning's occurring because there's creative tension that's created among those different modes of learning. And then as that students work around those and resolve that creative tension, they're remodeling their thinking, and that's where that learning is being created. So they're literally transforming their experience and what they know to be true. So then we're going to apply Kolb's experiential learning theory as an instructional framework for image evaluation instruction specifically. This isn't a direct quote from Bridge, but this idea was taken from a study done by Bridge et al. 2014 when they were testing the effects of a simulation platform that they designed called the MIDI. So unlike other professions where the goal of simulation is to provide practice in minimizing error, there is great value in intentionally simulating radiographic positioning errors in order to better understand their effects. So if you'll notice, I took Kolb's and I switched it. It's a cycle, you can start at any step. So for image evaluation criteria, we turned the wheel 180 degrees. So my students started with abstract conceptualization, and then we moved through the same cycle. So what this looks like is abstract conceptualization. The students first predicted the effect of a positioning error on the anatomic alignment of a resultant image. So if we were looking at a knee and we were saying, okay, if you have internal rotation in an AP knee, predict what that's going to look like on your image. So the students sat and thought about that. They wrote down their predictions, and then they actively experimented. They were expected to simulate that positioning error intentionally, and then create the resultant image. Then they moved to concrete experience. Once they had that resultant image, they practiced their image evaluation skills by determining what image evaluation criteria was not met from that definable standard. Then they moved on to reflective observation, and they looked back at their predictions. So they observed the outcome of the applied error on the simulated image, and then compared it with their predictions. Did they predict it accurately? Was it what they intended? If it wasn't, why not? What actually happened? What did they think was going to happen? Why didn't that happen if they were wrong? Then to close the loop, we had them, and essentially this is then another loop. We had them correct the error so that they would get a diagnostic image. So again, they had to conceptualize how to correct that error. Then they had to create that new diagnostically acceptable image. And then they had to evaluate that image to make sure that those criteria were now met. And then they had to observe and reflect and compare the first intentional undiagnostic image to the diagnostically acceptable image. So again, we have this think, do, think, and then there's grasping and transforming, and there's that creative tension that's created as we're going from mode to mode. And as learners are working through that, they're resolving that tension, and that's where that learning is really occurring. Is just another way, we're not going to go through this again, but this is what I had the students, they took out a piece of paper and just wrote these down. It was nothing fancy. It wasn't, they didn't even put it in the PowerPoint because they had virtual medical coaching open on their own devices, but they essentially wrote this same chart out. Here's the error they were working on, internal rotation. What did they think was going to happen? Once they simulated that error, what did they actually find? Were those the same? And that gave them an opportunity to write it down and then compare what they found and what they thought. So then talking about immersive and non-immersive virtual reality, I think we're probably, if I had to guess, all very aware of the differences, but immersive VR has much higher fidelity. We're really fully immersed in that environment, 360 degrees. We're moving, when we move, our whole body is moving to that same area. And why it's not the exact same muscle memory as if you were working with the actual equipment, it's pretty close. Compared to when you are on non-immersive and you're using different controls, you're using your laptop or your mouse to control these controls over here. So the fidelity is lower in non-immersive. When we first started, I was very disappointed. Immersive VR just wasn't feasible for our program at the time. We weren't able to really integrate it like I would have liked to, but I was happy to have the non-immersive. And once I got into this study and I got to working with it, it really, really drove home to me that one is not better than the other. It's really about finding the right tool for the right job. And for us, we have a very unique situation where we have students across 5 different physical locations. We're talking about almost 40 students at, across 300 miles across our state. We really wanted to integrate it in the classroom. And so non-immersive allowed us to do that because our students have simultaneous access. Because you're not dependent on goggles and paddles in different immersive setups, our students are required in our program to have their own devices. So they already had their devices. Their devices met minimum standards because of the requirements that we require for our testing and Canvas and all the other software that we use in our program. And so they were able to very seamlessly get an VMC account, and everyone had it open. So Omaha, Kearney, Columbus, North Platte, Norfolk, all 5 of these places had it open. I was on Zoom, I was instructing across Zoom, and we were all able to work seamlessly at the same time in the software. And so that was a really big benefit and a really big win for us. And that was a really defining moment in my own research of working with VR of, oh my goodness, just because it's lower fidelity doesn't mean it's a lesser tool. So it's really, what are your needs? What are your learning outcomes? Maybe immersive VR fits the bill for your program. Maybe non-immersive is really what you need. Maybe you need a combination of both, depending on using those each to their strengths and really driving home an integrated curriculum that way. But it's not lesser, but it's about finding the right tool. And for our program, that non-immersive really is what we need. So then we'll move into the results of the study. We have Miller-Spin NABI 2024. We published this in June in radiography, like James was saying. And so I'm just going to very briefly summarize our main findings. We looked at a lot of different things across the study, but due to time, I'll try to get a whole dissertation and summarized in like 20 minutes. So looking at the methods, the aim of this study was to evaluate the effectiveness of non-immersive virtual reality radiographic positioning simulation software on first-year students' image evaluation of common positioning errors on routine knee and lumbar spine protocols. And so the 3 research questions that guided our study was, does guided instruction using non-immersive radiographic positioning simulation software lead to improved image evaluation scores? 2, how well do participants describe evaluation of positioning errors after guided instruction using radiographic positioning simulation software? And then 3, what are student perceptions of using this software for image evaluation instruction? There's very little work that's been published evaluating VR's instructional use and effectiveness of simulation instruction in radiography education. Really, in the last couple of years, I feel like there's been a boom. In maybe the last 2 or 3 years, there's really been an increase in studies. But when I started my work, there were, a handful of studies across several years, all of which were outside of the United States. This simulation's been commercially available for a while, and I feel like it's been embraced globally. Bridge also did an audit study globally, and the numbers aren't even close to, I think, if we did an audit study in the United States of what our use is here. We have some anecdotal numbers, but no formal audit study's been done. But I think the United States really is lagging behind in the global use of this. And so the significance of my study specifically is that it was the first one, maybe conducted is the wrong word. It's the first study that's been published from within the United States. It's the first study designed that primarily evaluated VR simulation's role in image evaluation using traditional lecture as a control. This one was really important to me because this is how our program taught it. Of course, there is a ton of image evaluation instruction that occurs in clinical placement, but that's not standardized instruction. It's based on where your student's at, what they're seeing, which technologists they're working with. Does that student connect dots on their own? So when we had our standardized image evaluation instruction in our program, we were using a form of traditional lecture. And so there's one other study, Alquist in 2013, had a similar aim, but they compared it to lab instruction. So it was non-immersive VR to lab work instead of traditional lecture. It's also the first study to evaluate virtual medical coaching's non-immersive or their desktop version. All the published studies at the time of my dissertation had looked at the immersive side, so it was exciting to be able to also look at the desktop version as well. First study to include data collection with an essay component. And then it was a first study with a distance education component. I'll tell you on the front half, we were very short-sighted. I was very short-sighted. Again, when it's what you do every day, you don't realize it's novel or it's innovative. We had an incidental finding because we didn't even really factor into the distance education component into any of our research questions. And so as we got to going and looked to control for different variables, we found that there was actually a very significant distance education component to it. The setting for this study, Public Academic Health Center. At the time of this study, we had between 31 and 36 students accepted per cohort. We've grown since then. Again, we talked about these metropolitan numbers, so I'm not going to run them by you again. But we have a metropolitan campus, a micropolitan campus, and then now three, but at the time of the study, it was 2 hospital locations. Students were used to the Zoom video conferencing used to deliver the instruction because this is what we use every day. This took place in the second semester, so regular classroom instructions delivered through Zoom with instruction originating either from the metropolitan or micropolitan campus locations. When students have skills lab, the instruction, it's on site, so there's no distance ed component to that lab. We have instructors at each of our sites that are responsible for teaching in person. But because we have 5 different program locations, we don't use any radiographic phantoms. You can imagine how expensive that would be across all those sites. And so no phantoms are used, which means the students have no resultant image. So they practice moving the equipment, they practice positioning each other, but of course they don't get to expose their classmates because of the ionizing radiation, and there's no radiographic phantom to expose. So they really are missing that critical piece of having a resultant image that's unique and based off of their applied positioning. They don't see that till they're in clinical placement. And then you're at the mercy of what happens in clinical placement. You can't make those mistakes on purpose, of course, on patients. We know we can't do that. And so really you're seeing, is that patient even connecting the dots when they see that happen? Is the technologist they're working with able to accurately articulate and willing to take the time to talk with the student about why that happened and how to correct it? So there's not that standardized piece in our skills laboratory instruction, and we just noticed that piece was really missing in our curriculum. Clinical placements for students are local. They don't travel. Our metropolitan students don't routinely come to micropolitan campuses or hospital locations, and likewise the students aren't. They're staying in that region and doing all their placements locally. During this study, the instructor for the study was physically located at the micropolitan campus. That was me. I stayed home. I wasn't able to go just due to logistics and the way the instruction was. I wasn't able to go campus to campus. And so all instruction came from our micropolitan campus, which was very, the students were very used to it at that point because that followed what all their other instruction had been at that point. I don't want to spend a ton of time on this. I really go into detail in the publication if you want to know more about our survey development. The tool we used images. These are the same image, but they asked 2 different questions. It looks like from this that they're presented right after each other, but we didn't present them, we mixed them up, and I didn't tell the students the questions were paired. They could only see one question at a time. So we had asked them, is there rotation on this image? And they had to identify if they could see if there was rotation. And we also asked them, that was one format, identifying the positioning error. The second format was, how do you correct this positioning error? Then their essay question, there were 4 essay questions on each survey tool. They were asked to critique for routine positioning errors and to be as specific as possible. There was also a perception survey at the very end of the study. There were 3 quantitative questions, which are displayed here. How easy was it to use? How helpful was it in learning? And do you want to continue using it? The 2 qualitative questions we asked that aren't listed here are, what did you like about using it? And what didn't you like about using it? We didn't get real fancy. We just wanted to know what they thought. So here is our study design, or our timeline, I should say. We had consent and group assignment. Then we delivered the pre-test for both the knee and the lumbar spine. So this was all during 1 week in the second semester, towards the end of the second semester. I believe at this time, students had completed either 27 or 28 weeks of clinical rotation or clinical placement. So remember, they have that integrated curriculum. They're in the classroom and the clinic at the same time. And so they did have some clinical experience at this point that they could rely on and draw from for this pretest. Then we collected the knee pretest data and the lumbar spine pretest data. And then the next week, we performed the knee instructional interventions. And what this meant is our classroom days are Tuesday, Thursday. So on Tuesday, half the students were split in half. Half of them received traditional knee instruction, so just a traditional lecture about knee image evaluation. And then the second group received their instruction for knee image evaluation through guided simulation. 2 days later on Thursday, they took the post-test. Really important, this was delivered during normal classrooms, so they all were expected to be there, but they didn't have to take the post-test. So when they consented to taking the pre and post-test and letting us use their data, but it didn't work into their course grade in any way. So they weren't being evaluated within the course. It didn't affect their outcome. They also weren't held to anything. So, there also is maybe arguably there wasn't any studying. So it was really truly evaluating just that instructional intervention, which we know is maybe not really how we teach in real life. We expect them to do some work outside of the classroom. Harder to control for that though. So then the next week we had knee, week 3. Week 4 of the intervention, we had the lumbar spine, and same format, but those that received traditional lecture for the knee now received guided simulation for the L spine. Those that received guided simulation for the knee now receive traditional for the L spine. So this is the crossover design. And then again, this was Tuesday. On Thursday, 2 days later, we collected the post-test. So the timing between them was all very similar. Then we had our analysis and then our interpretation. So here's what that crossover design looks like. Those that group 1 received traditional for the knee, guided sim for the L spine, whereas group 2 received guided sim for the knee and traditional for the L spine. For feasibility, we grouped our groups based on location. And so this created a really even split for us. We had students from the metropolitan campus and one of the micropolitan hospital locations for an N of 17. And then we also had our students from the micropolitan campus and then the other micropolitan hospital location for a group of 16. So it was a really serendipitous split for us to be able to do that because logistically it was much easier to control for who attended which lecture that way. We were very intentional with making sure that the instruction was structured similarly so that we really were testing the instructional format or the instructional delivery, not any differences between what was covered. So we used identical objectives. We had an identical review of relevant anatomic structures. Instruction, no matter which format was used, was presented by radiographic projection. It started with an ideal image and then the image evaluation criteria. And then we moved to non-diagnostic images by positioning error. So we worked through rotation, central ray position, and tube angulation. And then it just depended on which format the students were assigned to receive for each anatomic area. The difference of the instructional interventions is right here. So it was how those non-diagnostic images were presented by positioning error that differentiated traditional lecture versus guided simulation. So here's the objectives that were used for the L-spine. These are identical for both delivery formats. Here is, again, identical for both formats. Ideal gold standard image. I cut off exposure. It's definitely important. I also teach digital imaging, so it's also a pet topic for me, but not what we're looking at. So we cut it off so the students were really just focused on anatomy and positioning when they're evaluating this image. Then no matter what instruction they received after we talked about it, we all use the same slide for debriefing. So when we're determining rotation, what are we looking at? Where's that at? What does it tell us? So we debriefed the same. What was different was how those images or how that instruction was delivered to tell the students, here's what rotation looks like. Here's what clipped anatomy looks like. So for traditional lecture, it was very passive. There was no student engagement. There was no student interaction. The instructor just presented an image that had the positioning error on it. There was a gold standard in the corner to compare it to. And then the instructor just went through, here's what we see is not being met. So the SI joints aren't equal from the spinous processes, and the instructor would point out those different anatomic structures and walk through what those are. Versus guided simulation, the students, just like what we had talked about, the students were guided to create their own image, and then were tasked to apply that image evaluation criteria to their images, and then compare their predictions with the outcome, and then see if they were compare their predictions and the outcome, and then correct that image and create a diagnostic image. So instead of being provided with these images, they were creating them. Here's a picture of teaching in the classroom. You can see the students have their individual devices. They're open, they're out. And then this was also transmitted over Zoom. And so students at all locations could see, students were given time to do it themselves. And then I also would simulate them and make sure that our images were matching. Here's the statistical analyses that we ran due to time. I won't go through all of them. Looking at results, research question 1, this is really talking about the multiple choice questions. So does guided image instruction using non-immersive radiographic positioning simulation software lead to improved image evaluation scores? So when we looked at the multiple choice test scores, what we found that we first ran paired samples t-test to look at all the students across the board, regardless of whether they had traditional sim or traditional lecture or guided sim. Did they improve? First of all, was the instruction effective? Maybe I'm not an effective instructor. We want to find that out before we go and dig deeper. And so what we saw is both anatomic regions improved. The knee improved by a mean of 0.82 points. It wasn't a statistically significant improvement, but they did see a raw increase of almost a point. L-spine saw a mean increase of 2.91 points, almost 3 whole points, and that was statistically significant. When we look at these, the knee pre-score mean, so let's see where we're at, and this is across both, so don't look at this yet. Students scored on the pre-scores an average of 12.91, and then their post-score was 13.75. So there's where that difference of 0.82 is. Whereas on the L-spine, their pre-score mean was 9.33, so it was significantly lower than the knee's pre-score of 12.91. And remember, the L-spine saw that significant increase. And so their post score ended at 12.24. But interestingly, that L-spine post score was even lower than their knee pre-score. And so the students came in with probably more knee experience just from working with them in the clinic, from where they're seeing, maybe felt more comfortable with that, which was a little surprising to me. But I think hold on to that, because there's some interesting information later that maybe doesn't match up with their perception to reality. When we ran repeated measures ANOVA, so paired samples t-test looked at the cohort as a whole across the board, regardless of what instruction you received. That's looking at within group means. When we did repeated measures ANOVA, we were looking at between group means, and we used the pre-score as a covariate to account for the fact that they came in knowing less about the L-spine than they did the knee. And so when we did that, the repeated measures ANOVA demonstrated that there was no difference in the outcome based on instructional method, anatomic region, campus, or instructional sequence. And so none of these things were statistically impacting the outcome. Oh, also, there were two-way interactions. We tested for two-way interactions in that repeated measures ANOVA, and none of them were significant. However, because we had a small N, we did do an exploratory analysis because there was a non-significant two-way interaction between anatomic region and instructional method. You can see our P is 0.29, which is definitely far from our 0.05 of statistical significance, but we had a small N, so we just looked further just to see what was going on. And so just to quickly run through this slide, we have raw means versus adjusted model means. And we see some significance here. So raw means is looking from an average of 0, and if there's statistical difference from that. This is showing similar to what the repeated measures or the paired samples t-test suggested, that there was a statistically significant increase in the L-spine regardless of what instructional mode or delivery that they received. However, when you look at the adjusted model means, this takes the 4 averages, the 4 scores, and creates an average, and then it compares each of them against that average. And you'll see 2 of those are statistically significant, and they're not the same 2 over here. This one's really close to statistically significant, and then this one's not. Just different ways of looking at this. This is exploratory analysis, it's not priori analysis, and so these aren't saying the same thing as if we would have gotten p-values on their repeated measures ANOVA. What it does do is just indicate, hey, this may be worth exploring or investigating further in your future studies. And so looking at that and, well, what does that really mean? Right now, I don't really know, but I think it's interesting to see those breakdowns across there. Looking at the essay rubric scores, this is maybe one of my favorite findings we had. Our pair samples t-test showed no difference, no difference at all between pre and post-test scores. So you can see across the cohort, whether they received traditional or repeated or guided simulation, on the knee, they had a mean increase of 0.27 points, which in this case is almost negligible. And then the L-spine, they stayed exactly even. And I checked and double checked to make sure I didn't accidentally put my pre and post information in several times, and it's not. They literally had no change. They didn't get better, they didn't get worse. There was no change in scores across the entire cohort on the L-spine. So regardless of what this is saying, is there was no improvement. They weren't ready for essays. And so when we ran the repeated measures ANOVA in the same format we did for the multiple choice, again, demonstrated that there was instructional method, anatomic region, campus, instructional sequence, had no impact on their outcome scores. And then we ran 2-way interactions, and none of those were significant as well. Quick look at student perceptions. Ease of use, students really liked using it. So ease of use, 64% said it was somewhat easy, 24% said it was very easy. We had one orientation session of about 2 hours before we had started the instructional intervention. But other than that, this was new software to them. And so not surprising that the ease of use isn't very high, because they were still really new users to this. But even regardless, they were able to jump in and start using it right away. So if we look at a combined agreement score, 88% thought it was easy to use. Helpfulness, same percentages, they're just flip-flopped. So 64% thought it was very helpful, while 24% thought it was somewhat helpful. Again, combined agreement scores between looking at those who thought there was some degree of helpfulness, 88%. Very, very high compared to what some other studies in the literature have found. Of course, not to be neglected are the 12% of students who found it somewhat difficult and not too helpful. Then, not surprisingly, those exact percentages match up to continued use. 88% want to continue using it for image evaluation instruction, 12% would prefer not to. This is just one of the graphs, but I compared perception to performance. So I looked at ease of use, helpfulness, and continued use, and there was no significant linear relationship with student performance based on their perception. So what this means is students who thought it was easy to use didn't necessarily score higher or lower. Students who thought it was helpful didn't necessarily score higher or lower. That was just, they shared those across all performance scores. And you can see that that's spread out over here. Looking at confidence, not going to break down the statistical analysis, but you can see blue's pre, green's post. So confidence, regardless of what instruction they received on what anatomic region, confidence was definitely increasing across the board. Again, confidence didn't have a significant linear relationship with performance. So again, our students may be not always in touch with what their abilities, their perceived abilities and actual performance are, which as educators, I think we all can agree with. Looking at a brief discussion to also keep time for you to ask any questions. Main finding of this, no significant difference in student performance by instructional method. What this means is that guided simulation instruction is as effective as traditional lecture in teaching image evaluation skills. So both anatomic regions saw raw score increases. L-spine saw statistically significant score increases. But regardless of what they had, there wasn't a difference in performance. So this is saying that, we are as effective as what we were doing beforehand, but now we have additional benefits. And remember, this was a very frozen, and most studies are, but frozen in time. This was after one instructional session using guided sim. It was very new to them. We hadn't integrated it into the curriculum. It was a very new just snapshot of their skills. So I'd be curious if we could extend this out and look at students more than just one interaction. What would this say? Would we see that VR is actually more effective than traditional lecture? Maybe, maybe not. But I think we would at least continue to say it's as effective. But I would think that over time, when students are more integrated and used to that format, that it may even surpass it. But that's just my own, I have no data to support that. That's just my gut. When we look at the multiple choice questions and the essays, remember that essay saw no difference across, like literally no difference in the L-spine. But when we step back and think about this, these are novice learners. This was one instructional session. They had instruction on Tuesday, they were tested on Thursday. There was no grade tied to it, so they didn't have any skin in the game to make sure they performed well on that post-test. And so it makes sense that those essay questions didn't see any change because we're asking them to perform higher up in Bloom's taxonomy. Multiple choice questions are really asking them to understand. It's lower, it's giving them an image, it's providing them answers. They have to recognize from those answers I gave them what's going on in that image. What this told me was the essay questions asked students to independently do that, and they weren't ready to do that. There was no difference. They either came in knowing it and they left knowing the same thing. And so there was no change in that independent skill, and that suggests they need a lot more practice. They need a lot more time spending and a lot more images to look at and really get comfortable doing that independently. So not a surprising finding there. Then looking at distance education, non-immersive VR benefits in education. I think there's an incredible distance education potential. Immersive VR offers increased fidelity and presence. Non-immersive VR requires less hardware and physical space, which was an incredibly important consideration for our program for this study. Instructional efficiency was increased because all users were able to access the simulation software at the same time, and it allowed simulation use during classroom instruction. And so I was able to merge my traditional, what I would normally communicate during traditional lecture, and let them explore and discover that on their own by creating those images and then apply that. That's not likely to happen with immersive because everyone's immersed in their own bay. And so it's just not really set up for classroom instruction. So again, one's not better than the other. High fidelity doesn't necessarily mean better. It's what your learning outcome is. It's what your learning environment is. It's what your students' needs are. Where are they physically located? Do you need one or the other? Do you need a combination of both? So something I just hadn't appreciated until I had completed the study and really stepped back and saw what it afforded us to do. When we were able to use it synchronously in the classroom, we were able to close the theory practice gap because we no longer had separate classroom and skills teaching. It was classroom and skills together that were integrated during that guided simulation instruction. We had the same results for students across campus. If you remember, in one of those, there was the performance wasn't determined by the campus. And that's what we strive for, especially when we're constantly working across 5 program locations. We need our students to have equitable experiences, equitable outcomes. And so this is exactly what we want to see. So we want the students having the same results. We want equitable experiences among all locations, and that's what we saw. Our students that weren't in front of the instructor performed just as well as students who were in front of the instructor. The only statistical test that we ran that had significance based on campus or program location was helpfulness. And so we had one of our micropolitan locations wasn't too keen on using the software in general. And so they had a much lower helpfulness score, saying they somewhat disagreed that it was helpful in learning image evaluation scores. However, that was only one micropolitan location and it had an N of 2. And so with an N of 2, it's hard to tell, was that really had to do with the location or those specific students there? It's, this one kind of frozen in time. But if you look at the other campuses, they had very high scores, very similar to the campus that the instructor was on. And so I think this has more to do with the specific learning preferences of those students and very little to do with the actual campus. We can't pull that out, but just my experience working with these students, working across campus, I really think that's what we saw here. And I think the fact that their performance was just the same, no matter which of the campuses we were talking about, there was no difference, no determination based on that. Really, we're seeing that equitable experience across campuses. So that has significant potential for distance education that we haven't explored before. I'm not going to go through this based on time. I'm watching the clock. Basically, this is saying it's supporting existing literature that the majority of students are going to agree that their skills improve regardless of whether they had traditional lecture or guided simulation. Great, we're seeing that instruction improve or that confidence improve no matter what. That's what we want. Other studies have found that to be true as well. Again, as effective as traditional instructional methods. So at this time, I have a conclusion. We can wrap it up, but I think we've spent a lot of time talking and I definitely want to hear from you too. So I'd open it up for any questions you have about anything and happy to answer whatever you have for me.
Thank you very much, Ellie. I absolutely loved that. I was expecting something amazing, and you blew it away. So, thanks very much. I don't know if everyone saw my question, but since it's in the chat, but I may have put it in the wrong chat. You used a different platform during this time. So it was about 3 or 4 years ago, wasn't it? How do you think the new platform would compare for student helpfulness and also instructor helpfulness?
That's a great
And also,
question.
I know I am obviously biased here, but this this isn't going to affect anything. I'm just curious.
No, I don't think I have a great answer for you, James, because we used the synchronous in-class instruction for this study only. So this was performed, trying to think, 4 years ago. Nope,
Yeah.
That's not right. 3 years ago. The study was performed about 3 years ago when we were in the old platform. Since then, we've used the new portal, but the students have asynchronous assignments they're using to complete. And so that's a whole different conversation we could use. We're not using it in the classroom yet, but coming this spring, we'll be revising our image critique, our image evaluation section of one of our courses to incorporate it for half the semester, where we're using this Kolb's experiential learning theory to frame as instructional framework for that going forward. We're going to integrate it into the curriculum.
Okay, that's great. And I just, you mentioned something about the way you set up the University of Nebraska because of your 5 campuses. And that one of the reasons for going full desktop mode was due to the hardware requirements. Now, there is a chance you will see something thrown at me in a minute from one of the developers who's sitting on the other side of the room. But we're about to go, and I'm always far too ambitious with my timelines, but we are about to go to standalone only headsets. Oh, here we go, Faith. Do you think that would make a difference for having, so that would mean you're getting rid of the PCs for each student. And then an Oculus Quest 2 in the USA is about $300. And I know, and one of the big pushes for this was actually a university in Michigan who they deal with an even bigger area than you do, and they give all of their students a headset and a computer at the moment. It's 100% online, plus then visits to the hospitals. And obviously the headset plus a PC is a financial barrier for having more students, whereas the headset alone, especially now that they're so cheap, and I say cheap, I'm not disrespecting that sort of money, but for an institution, it's minimal compared to for a 19-year-old student at home. Do you think that would make a difference with your 5 campuses?
Tell me more what you mean by standalone headset.
Oh, so sorry. Okay, so
yeah. Tell me
so
more.
At the moment, to use virtual reality, we have, and I can show you one of mine here. So this is an HTC Vive Pro, and I'd have to turn off my background, but you can see there's got a cable on it. And what's that? Oh, okay. Manny's just giving me some ideas as to put it here. So it's got a cable on the back, and that's connected to a computer. Now, so essentially the headset is running off the graphics cards from the computers. Now, the reason we did that to begin with was our simulations are quite powerful. And this isn't me just being conceited, but to do that, what you were talking about, turning the knee, turning the lumbar spine, creating the wrong image, we have to create images on the fly, which when we started this, which was 9 years ago, I only found that out the other day, the graphics cards of the headsets just weren't up to it. They were for sort of games, whereas our bodies in our virtual reality are full of bones and organs and things like that, as you know. So now with some of the later generation headsets, with a lot of work from the developers, they've created a standalone version. So you'll just be able to put your headset on, log in, and go for it. So, and that also stops, there has been a concern from some people, like, will students trip over the cable? Actually, students just know that they're there. They have, I often refer to my 7-year-old daughter who knows how to use computers and phones like that. I don't know how she does. She can tell me what to do usually, but they've never had an issue with cables. But if it's a concern for some people, it's a barrier. So it's a good thing that we're getting rid of that.
I could see for our institute, I'm talking very, very narrow focused in what I know from my institution. I think that opens up accessibility into increasing and expanding out into immersive. Right now we have a bay in Omaha, and they used to have 2, but only 1. So they're down to 1 now. So to get 17 students through that 1 or 2 bays that we're set up for currently would be very difficult. Whereas if we can have an open space where we could have multiple students in freestanding headsets doing immersive things, or doing immersive simulations, then yeah, I think for us that would open up accessibility a ton, because then we're relying less on what other people are providing for us or what space we can find to have that technology, versus just finding the open space to be able to do that. Or even, it sounds like Michigan, are they sending that home with them? Because it's an online program, so that students able to do it from wherever. So it kind of opens up.
Yeah, the students get one and they get it to keep, which is quite a draw card for that university. You know, if you're looking at a couple of different programs and you're like, oh, I get these free bits. It's like decent swag. Look, I think Faith, you had a question.
I didn't actually have a question. I've got a comment. I mean, James would know. It took me 4 months to actually get a computer at my institute that could actually run the software, and to then purchase it and things. And I'm like, can't we have it stand alone? And this is something that's amazing, because I know that the students, I think, the ones that I told about before were saying everything's too expensive. Now, when I mentioned a couple of weeks ago it's going standalone, they're saying yes, but then they could even buy the say, for example, the MetaQuest 2, because that one will work with it as well. So they'll be able to purchase that, which is half the price really of, like you said, $300 less than that. And they go for that, whereas they would have had to spend over 2,000 euros on a gaming computer, plus the headset. That's going to cost them at least up to 3,000 euros. So thank you for doing that. It's really a blessing. And for me, my students, I only have 14 to 16 students per year. So all my students will be able to actually, or most of them will be able to have a headset. So thank you very much.
Oh, that's really cool. Fantastic. Well, actually, it was partly because of your emails every week that we got on with it.
And the update was fantastic. The update was fantastic because that allowed me to be able to use even the cable, the MetaQuest cable itself.
So we've got another person on this called John McInerney, and as you can probably guess, Faith, he's from our neck of the woods as well.
Oh, okay.
And he was a good instigator onto that new update, because in the university John works at, they were having trouble with the cable as well, and we've got to follow up on that actually. But yeah, so I'm glad that that sorted it.
If you bought a new fiber optic cable, you needed to actually use the old USB 3 instead of the USB-C, because it just wasn't working.
But getting back to your actual question, getting back to your actual question about the university not providing you with the right computer for 2 months, I've obviously got to be careful with what I say, but that is a sort of a fault of the ICT team you're working with. And I know how competent you are with hardware. Sadly, you're down in the Apple side of the fence. But anyway, we'll let you off. You know, and that's often the same with any large university providing slightly different things than the standard. So they can get you laptops for anything, and then you're like, oh, hold on a second, you want to use one for virtual reality, that needs to go through a different procurement department or something. And as soon as you get someone saying to you it needs to go through a different anything, you know it's going to take 2 months.
And as you know, I had to go and get a grant for what I purchased. I didn't even get it from my institute. So I got the grant, I purchased whatever I needed, and I'm very happy we can continue, and I can continue with my studies and do whatever I need to do. But thank you for everything. And thank you guys for everything. Very good.
We had a similar experience, Faith. We had another department at our sister university that Kearney's located on. So I had a department in UNK with 4 Oculuses that were willing to let us borrow it for a pilot, but we couldn't find a gaming strong enough PC to run them. So we even had the Oculuses in our hand on my desk for months, and we still couldn't connect them. And so we ran into a lot of barriers where it wasn't being integrated into our curriculum, so we couldn't pilot it. And when we have 5 campus locations, we can't just do it on one with students with others. So we ran into a lot of barriers, which led to the use of the non-immersive, which I said initially I was disappointed because I really wanted to do the immersive. And then when I got into it and got using it with our students, it really drove home of the right tool for the right job. And that was really, I think, what we need. And so it was very eye-opening to see that higher fidelity for us, specifically in our unique situation, wasn't necessarily the only tool. And so it was great to see the power of non-immersive too.
I had access to 6 headsets and I couldn't use them. But eventually I was in a meeting and saw this guy's name from computer science. From computer science. And he actually then said, I've got a computer, you can borrow mine for a couple of months. And that's how I got to influence a lot of people or my colleagues and say, we need it. So yeah, it took a lot. But now I can borrow those headsets, plus I've got our own, and we're going to get 2 more, so that will help.
Great work.
Yeah, okay, please, can I say something?
Of course.
Yeah, I'm Sobechukwu from Nigeria, senior lecturer at University of Nigeria. I'm also a radiographer. Just a little bit on the experience on using virtual medical coaching. The headsets, I managed to find a way across them, especially I used MetaQuest 2 and then recently upgraded to MetaQuest 3. And then I've used them without cables. So the MetaQuest 2 and 3, they have specific graphic cards that you need to run them. So I think there in their website, they have the list. So I managed to get the list and then got the specific computer system. And then you could do away with the cables. So whenever I set up a virtual medical coaching, I set them up without the cables because you need an ICT fellow to connect the router to run at 5 gigahertz. So you can transmit at 2.4 gigahertz and 5 gigahertz. So if you transmit at 5 gigahertz, then you should be able to run the headsets without any need for cables. So once you get the computer with the particular graphics card, I think they work mainly with NVIDIA GeForce cards. So once you're able to get them and then get the appropriate connection, then it will work perfectly well. So all the places that I've set it up, so I set up virtual simulations here across Nigeria. I mean, we've had that. We've not had that problem of maybe cables, everything, etc. So maybe I was asking Ellie if maybe was it that you never had an opportunity to use the virtual reality that you now went for the non-immersive version? Because from my experience here, I'm actually running a study on using virtual reality as an adjunct for clinical training. So rather than pitting it against each other, that's one of the questions that I asked. So maybe I don't know whether students have had the opportunity of using the immersive version, which made you to go for the non-immersive version. Thank you.
Our students haven't had the chance to try the immersive just because we're located across those and we don't have them. So we're working, Ashley and I are working, we've had discussions, we're slowly thinking of ways to get there. It's on our radar, we just haven't been able to prioritize that component of the study yet. But I love your question of pitting it against, because in reality, really one's not going to replace another. We did it to try to isolate effects and try to parcel out, because if we tried to do traditional lecture and add, then is it the guided simulation that caused the increased score or the increased performance, or was it the additive learning, right? So we really, for the study, pulled them apart, even though in reality, we were not going to replace traditional lecture with this. We're going to implement, or it's going to be a complement. So when I revise our image evaluation criteria next semester, we're still starting with a faculty lecture, traditional lecture. Here's an image, it's good because this. Here's an image, it's bad because this. Then we're going to spend the next 2 or 3 weeks with the students in virtual medical coaching, using Kolb's, practicing and initiating that. So we're going to integrate and marry both of those, because I am a firm believer. Big component of active learning, big component of engaging students, but there's still a place for traditional lecture. I think as an instructor, you hold that expertise, you hold all of that knowledge. There is a time and a place to go ahead and be the sage on the stage. And then there's also a time and a place to let your students explore and you're really using those two methods together to have a synergistic effect, so they're learning and being able to apply. So fully agree. I love that question.
Well, thanks, Ellie, and then thanks, Subeku. I think you're using the Airlink, and I know that. I don't usually recommend that. It does work, but like you say, you've got to set up your router differently, and sometimes this throws people into a chaos. So we usually keep it quite quiet because we knew the standalone version was coming out. but yeah, I know it works for you because you sent me the photos of all your students using it, and I was like, oh, I see what they're doing. But yeah, so that's really good, and I was glad you had that sorted. Ellie, again, thank you very much. That was absolutely fantastic. We probably, I'm not sure if you'd like, but if anyone wants Ellie's contact details, would that be okay? Yeah, I should have asked you before you were on camera, sorry.
That's totally fine.
Because you might want to talk about how they do their work, because it is absolutely fantastic, especially with that unique environment where they're sharing things over 5 campuses. So again, thank you very much. Lovely to see you all. Hikmet, we've got to let you get to bed now. And I promise the next one will be more in your time zone, okay?
For better education.